Hello everybody, it's for me a pleasure to be here again. Now we are going to talk about injuries in the ankle ligament complex, and we will start the video just now. Excuse me. Okay. First of all, we are going to talk about injuries in the anterior talofibular ligament, which is the most important by far. The second one is the calcaneofibular ligament. The third one is a new ligament discovered 3 years ago, sorry. But is it a new ligament really? We are going to talk about it. The third ligament will be the anterior inferior tibiofibular ligament. Then we are going to talk about the dorsal calcaneocuboid ligament and the bifurcated ligament. And finally, the talonavicular ligament. And we also are going to check other structures, not ligaments, but there are other structures which can be broken or injured, and we are going to review these other structures. Because this video will take too many time to talk all about all these things, I divide it in two parts. The first part, we are going to talk about these topics: anterior talofibular ligament, calcaneofibular ligament, the new ligament, and the anterior inferior tibiofibular ligament. Okay. If we can make some explorations before applying gel, we will have a better evaluation of the structures in general. First of all, we can have a normal patient with a normal foot. Okay, this is not a severe injury, sure, but sometimes we will notice this foot here with the local edema in the lateral malleolus. This is the typical anterior talofibular ligament. This is the typical one. But other times you notice this inflammation of the ankle, in the lateral malleolus, but in the medial too. I call this inflammation the ring inflammation or the tennis ball inflammation. And be careful, because this inflammation is telling us that something happened inside the joint. Maybe a contusion, maybe a secondary damage, maybe even a fracture. Okay, be careful when you find this inflammation, this kind of inflammation. Sometimes it will be an affection of the lateral and the medial side, but at the same time. But it's not unusual sprain. It's different. Other possibility is the socks-like inflammation. All the foot has edema or inflammation, and it may be because some people have insufficiency of the vascularization return, but other times be careful, because it is telling us if the patient has cannot load on this foot 2 weeks after a sprain, and you find this inflammation. Be careful, because you need to assess, you need to evaluate. It's not a fracture. Okay, it's very, very typical for those people who are 2 weeks after a sprain and cannot walk. That fracture has been hidden and has not been discovered. So be careful with these patients. And you will have hematoma, and it's important because something has broken, but the location of the hematoma is not so important. Okay, you can get wrong if you think there's something here, because edema goes with the gravity. So the presence of edema may be important, but not the location. And the limb, if the patient cannot walk properly and you are 1 week or 2 weeks after a sprain, just be careful, because maybe you can have a severe pathology. Okay, next, the exploration. First of all, we see the edema, and we are going to palpate the foot. Searching the tender points at the palpation is very important too. First of all, I usually check the anterior talofibular ligament in the lateral side, just in the anterior edge of the fibula here. The second ligament I check usually is the calcaneofibular ligament, and so the peroneal tendons in the retromalleolar situation. Then I check the anterior tibiofibular ligament, the anterior joint, the anterior recess. I like to palpate the anterior recess. Sometimes it's painful. The bifurcate and the calcaneocuboid dorsal calcaneocuboid ligaments are located here. Don't forget to palpate these ligaments. And the talonavicular ligament in the anterior side here of the foot. Once we have palpated these ligaments, you must also check the fifth metatarsal to avoid some fractures in the base of the fifth metatarsal. Okay. Percussion is another tool I use in my consultation, and I perform this percussion of the fibula of the medial malleolus, and I use the percussion of my fingers, not the hammer. Okay, and it's more sensible to detect bone edemas or bone fractures, maybe non-displaced bone fractures. With palpation, usually it's not very sensitive, but percussion is more sensitive. Dynamic maneuvers. I check the Chopard and Lisfranc joints. I check the tibiotalar joint here, and I check the peroneal tendons, tibia posterior tibialis and anterior tibialis tendons, and the strength of these muscles. Also, when I check the peroneal tendons, I check there is no instability at the peroneal tendons. Yeah? Conclusion: once we have performed this evaluation, we can suspect some pathologies. First of all, a ligament sprain located in the ligament affected. Okay, this is the first thing I can suspect. But other times, after this exploration, I can suspect a fracture or a bony affection. Okay, trabecular fractures, bony edemas. It depends on the patient. Peroneal tendon injuries may be suspected, can be or could be suspected. Sorry, with this evaluation. Osteochondral bone edema suspected. I cannot be sure there's something broken, but you have this ring edema, you have discomfort with the load, okay, and this is not normal in sprains once 3-4 days have passed. So I can perform my evaluation with this orientation of the clinical evaluation first. You will be more sensible and more sensitive and more specific in your evaluation. Once we have checked the patient, we start with the pathologies of the ligaments, okay? And the first one is the anterior tibiofibular ligament, anterior talofibular ligament. You can check with ultrasound if it's a severe affection or is a mild one. The grade 1 is the hypoechoic ligament without interruption, without loss of continuity, without a tear. Okay, this is the normal side. This is the contralateral side, and in the affected one, you can see this thick hypoechoic ligament without loss of continuity. And there's a mild severity of the symptoms usually, and it's a good prognosis, and you have no problem at all with these patients. Second grade is a partial tear. This is the normal side again, with the fibular pattern of the ligament, of the anterior talofibular ligament, and in the other side you can notice here this thickening of the ligament, and you can notice here this partial tear with the joint liquid getting inside the ligament. This is a nice view. It's not so frequent because you need the patient to be very acute, because once 2 or 3 days have passed, this tear is filled with I can see the fibrous structure, and is not anechoic. Is is hypoechoic, so it is more difficult to appreciate. Okay, to see. Sorry. The third type is the complete tear. This is again the normal side with the fibular pattern, and in the affected side, this complete tear with these stumps of the ligament and an anechoic image, which is the joint, the synovial liquid between these two edges, the two stumps. Okay. Again, this is an acute image. Okay, we are seeing here an acute sprain, very acute. Okay, these are the three possibilities of the ligaments: distension without tear, partial tear, and complete tear. We're going to check now the calcaneofibular ligament. We're going to remember its anatomy because it's very, very important, and I recommend you to check the video of the anatomy of the ankle ligaments. Remember that this ligament is stretched in dorsiflexion. So if you ask the patient to dorsiflex its ankle, you will succeed to get tense, to straighten the ligament, and this ligament pushes the tendons superficially against the probe. This is the usual maneuver to check the calcaneofibular ligament. But it's not always like that, as we are going to see later. Okay? Now we are going to see some examples of the affection of this ligament. First of all, a normal ligament with this fibular pattern in the dynamic maneuver of dorsiflexion of the ankle. This is the peroneal tendons, this is the ligament, the calcaneofibular ligament, this is the fibula, and this is the calcaneus. Okay? And this is an example of an injured ligament with this hypoechoic thickening of the ligament. This is the fibula, this is the calcaneus, and these are the peroneal tendons. Okay, and you can notice with the dynamic maneuver, this ligament becomes more tense, and you can not see any area of tear inside the ligament. Okay, so perhaps we're not very, very sure this is a mild grade 2. It seems a grade 1. Sometimes you will have doubts. Okay, and this is a contralateral ligament. We don't have doubts. This is an injured, this is an affected ligament, and this is the contralateral one. Okay, we're going to see another example. This is the fibula, this is the calcaneus, and the peroneal tendons, and you see this hypoechoic thickened ligament here. Okay, and we are going to check its behavior with dynamic maneuvers. There's no good tension. You can see here how this ligament is not as is narrow here. We can still see fibers, but it's narrow here. It's narrower. Okay, so and in the contralateral side, you can see here the ligament with its normal aspect, its normal shape. Okay, so this is surely a grade 2 injury of the calcaneofibular ligament. Now we are going to check this other patient dynamically. You see peroneal tendons, you see calcaneus, you see a bony avulsion here, and the ligaments are very, very close to the bone. There's no tension with these maneuvers, and in the contralateral side, the ligament is perfectly normal. Okay, so this is grade 3, a total tear, a total rupture of the calcaneofibular ligament, even with a bony avulsion. So we are going to check now what about these dynamic maneuvers of the calcaneofibular ligament. Usually the classic conception, anatomic conception of this ligament is this vertical, slightly posterior direction of the ligament here, like this. Okay, but These authors on 2017 told us that usually the ligament is not as simple. There are many variants of the direction of this ligament, and even they went far worse, because they tell us that usually only in 44% the ligament gets strengthened or tense with dorsal flexion, and 55% with plantar flexion. So I'm not so sure about that. Usually I perform always in calcaneofibular ligaments dorsiflexion of the patients when I evaluate this ligament, and my personal perception is that usually with dorsiflexion of the ankle you notice that the ligament gets tense. Sometimes it is not this way, like we have just seen in the real-time demonstration of the ligaments, but the normal variant is that you usually succeed to straighten this ligament with dorsiflexion. Okay, so I'm not so sure about this distribution of the anatomy and its relationship with the dynamic maneuvers. But I want you to notice that sometimes when we have an injury here of the calcaneofibular ligament and we perform this dorsiflexion and we notice nothing is happening, just check the plantar flexion like in this way, and you see here how the ligament becomes tense with plantar flexion. See the orientation of the ligament, very, very horizontal. Okay, in these cases, check if you notice that the dorsiflexion of the ankle doesn't move the ligament, just check the plantar flexion. Okay. And what about the new ligament? Okay, we have checked the anterior talofibular ligament, the calcaneofibular ligament, and what about the new ligament discovered in 2018 by the anatomist of Barcelona? Okay, let's take a closer look to this new ligament. Okay, if you remember the anatomy of the anterior talofibular ligament, there's a superior fascicle here, which is a thickening of the capsule. It's intra-articular. Okay, and the normal variant of this ligament has two fascicles, the superior one and the inferior one here. Okay, so if we have here the superior fascicle intra-articular and we have here the calcaneofibular ligament, between these two components we have the inferior fascicle of the anterior talofibular ligament. They usually called like this, the inferior fascicle of the anterior talofibular ligament. Okay, these anatomists tell us that there is a complex. There are not two ligaments, but a complex called lateral fibulo-talocalcaneal ligament complex, because there are some fibers, artiform fibers, joining these two fascicles, the two components, and these two ligaments act as a unique ligament. Okay, and it's extra articular. Okay, this is perhaps not very practical, but it's interesting because sometimes when you are checking these ligaments, you will notice some things that now can be explained. Let's take a look to this example here. And we are checking here the anterior. Okay, this is the fibula, the talus, and here's the anterior talofibular ligament, the superior component. And there's a mild injury here, a mild strain. And as we go down, we see this edema, this affection of the inferior component, which continues. I turn the probe, and here this is the peroneal tendon, and this is the calcaneofibular ligament. So there's a continuity because the calcaneofibular ligament and the inferior component of the talofibular ligament, and sometimes it could be affected. So don't stop here in the superior fascicle, always continue distal, because you will miss sometimes injuries at this area here. Okay, perfect. And to finish, the anterior tibiofibular ligament. These ligaments are called the high ankle sprain, and 20% of the ankle sprains have an injury of this ligament. Usually a mechanism of dorsal flexion and external rotation is needed, very common in soccer. And in some cases the interosseous membrane could be affected, and this is a severe injury. Don't forget the orientation of this ligament, this tibiofibular, anterior tibiofibular ligament, 45 or 50 degrees. And this is a comparison between the normal side and the affected one here. Okay, you can notice the thickening, hypoechoic affection of this ligament without loss of continuity. Again, this is a grade 1. Grade 2 here, with this normal side in the contralateral side, the healthy one, and the affected, with this small tear in depth here and here. So this is a grade 2, and the thickening and the hypoechogenicity of the ligament, sorry. And this case is of the Dr. Pedret, because I hadn't any cases of a complete tear here. You can see a complete tear of this ligament, and this is the video with dynamic maneuvers with external rotation of the ankle with the knee flexed. You can notice here the complete tear here. Okay, too much here of the ligament. Okay, and that's all for now. Next video will be about the next ligaments and other structures which can be affected. Okay, remember, the most important, the anterior talofibular ligament. Always check the calcaneofibular ligament dynamically, and don't forget to test plantar flexion if dorsiflexion doesn't stretch this ligament. Always check the anterior tibiofibular ligament, because it's a more severe injury. And don't forget to explore the patient and to perform your ultrasound evaluation according to this exploration. You can check everything, but you must be especially careful if you have a suspicion of some structure affected. Okay, you will be more specific and more sensible in your explorations. Thank you very much. I'm Iriarte, and I hope you liked the video, and I appreciate if you want to leave comments about the ligaments or the injuries. I'll try to answer all the comments if I can, and to subscribe if you want to receive more notifications of more new videos. Thank you very much.